Hello, I'm Dr. Jennifer Woodward, a family medicine physician here at KU, and I'm thrilled to welcome you to the KU Primary Care Brain Health Program. As primary care providers, we all play a pivotal role in the fight against Alzheimer's and other dementias. Cognitive decline is a growing health crisis affecting millions of Americans. With specialists in short supply, the reality is clear. Primary care must be at the forefront of detection, diagnosis, and treatment. Our trusted relationships with patients and families put us in the perfect position to make an impact when it matters the most. The need for action is urgent. Many cases of mild cognitive impairment or early dementia go undetected or misdiagnosed. This delays care when interventions can make the greatest difference. Early detection isn't just about catching the disease sooner, it's about improving outcomes, supporting families, and ultimately enhancing the quality of life for our patients. Through this program, you'll learn how to detect cognitive changes early, work up patients with confidence, and accurately define the stage of impairment, whether it's subjective cognitive impairment, mild cognitive impairment, or dementia. We'll also focus on diagnosing the cause, including Alzheimer's, vascular dementia, or something else. In the end, we hope you'll feel confident treating your patients effectively with evidence-based strategies. To support you in this work, we've developed powerful new tools in our electronic health record to streamline your process. These tools include a cognitive assessment visit smart set, a note template, referral pathways, and Alzheimer's blood biomarkers. These tools will make your job easier, more efficient, and aligned with best practices. I'll guide you through how to use them during this program. First, you'll hear from Dr. Ryan Townley, who will walk you through the essentials of working up, diagnosing, and treating cognitive impairment. Then, Dr. Jeff Burns will share exciting advancements in Alzheimer's blood biomarkers, explaining how and when to use these transformative tests to increase diagnostic confidence. Finally, I'll return to show you how to bring it all together using the new tools in our electronic health record and when to collaborate with the KU Memory Clinic. This is an incredible opportunity to strengthen our role in the fight against Alzheimer's disease and dementia. Together, we can make a real difference by providing early, accurate, and compassionate care to our patients and their families. Thank you for your dedication to this critical work. I look forward to joining you on this journey.
Hello, everyone. Welcome to this series where we're going to really go over how to diagnose and treat patients with Alzheimer's disease and related disorders. I'm Dr. Ryan Townley. I'll be your guide through this. Our goal of this is to try to distill this complex information down into 5-minute talks with multiple talks to allow some brevity and space between the talks. Ultimately, we'll be trying to help you as a clinician detect, work up, diagnose, and treat patients with cognitive disorders. We'll start with a talk on improving our early detection of these disorders, and then we'll discuss the cognitive assessment visit, which is really the integral portion of how to do this in the clinic setting. We will have a talk on the recommended cognitive screening tools to use to detect cognitive impairment. Once you've detected cognitive impairment, how do you stage it from mild cognitive impairment to dementia stages? And then what does a workup look like once you do detect cognitive impairment? How do you define the clinical syndrome? Is this a primary memory or amnestic disorder or not? And then once you've got all this information, how to deliver a diagnosis, usually requiring a separate visit with the patient. Then we'll wrap up with some treatment options with 3 different talks on cognitive medications, behavioral management, and lifestyle. Now, we will have deeper dives available. We have a whole series of talks kind of distilled down into 13 minutes on how to interpret these new blood-based Alzheimer's disease biomarkers. That's led by Dr. Jeff Burns. We will have a talk where I'll discuss how to administer the short test of mental status, which is the cognitive screening tool we recommend. We'll go over some neuroimaging, how to look at an MRI of a patient that you might have ordered in someone where you're trying to investigate their cognitive impairment. We'll also discuss some more rare clinical syndromes, things you will encounter, but obviously not as commonly as the ones we discuss in these bite-sized talks. And then there are, of course, the previous pocket talks, which I've given where we have longer versions of a lot of these more nuanced discussions. And these are still within 20, 25-minute sizes, but obviously for longer topics than what we're discussing today. The first topic will be how to improve the early detection of cognitive impairment in patients. Just know that this is considered best medical practice. We need more timely evaluations and diagnoses early on in the disease process before billions of neurons are lost. This not only improves clinical outcomes, but also care partner stress and overall outcomes for patients and their families. Also know that these new Alzheimer's treatments that are approved work best at the early stages. So there are multiple reasons why we need to improve our early detection of these cognitive disorders. So who should we be screening, right? Do we screen everyone for cognitive impairment? No, but if a patient self-reports cognitive, behavioral, functional changes, if the care partner or family member reports these changes, or if you as the clinician or one of their other clinicians raises concerns about these changes, then those are who we should be screening. You do have to establish a bit of a triad relationship here. So clinician, patient, care partner as a triad. Now, within this triad, we want established shared goals, and everyone needs to be on the same page that we are pursuing a workup, ultimately leading to a diagnostic disclosure. So, when should we be asking about cognition? In general, once patients are reaching age 65, which is right around our Medicare wellness exam visits, we're almost near 10% prevalence of mild cognitive impairment at this age. And you can see that that ticks up each 5 years of life. Now, know that this is just talking about mild cognitive impairment estimations. If we look at folks with dementia, you could almost double these numbers and know that if someone has mild cognitive impairment, about each year, 10% of those individuals develop dementia. When we look on an average across 5 years, about 35% of individuals with mild cognitive impairment, especially when we know it's due to Alzheimer's disease, will develop dementia within 5 years. So who should we be asking, right? So, um, if you just take the subjective history from the patient, you're gonna get normal aging symptoms overemphasized, and you're gonna miss true memory problems in most individuals. So that's where this care partner really is key towards getting the best history that you can, which ultimately is the most important piece of the puzzle. So how to navigate that is different with each patient, obviously. So this has to be patient-centered. But a common one I will use is, sometimes when we have early memory problems, we might not always remember them. Are you okay with a family member weighing in on this? And I list this 88 form because it's a really nice, simple tool to use that takes less than a couple minutes to fill out. It is 8 simple questions that are yes, no. And if an individual is scoring at least 2 or higher on this, then it's considered positive, where you'd want to definitely consider further screening. And this could be either mailed, done over the phone, or in person with the loved one. So if this individual started to check some of these boxes, we would want to screen them further. So should you schedule a cognitive assessment visit for your patient? Say within your Medicare wellness visit, you do a quick mini cog screen and it's abnormal, then yes, you should do a detailed cognitive assessment visit. Don't assume that this is normal aging without an appropriate valuation. If there's concern by the physician, the patient, or the family member, then the answer to that should be yes. An abnormal 88 screener, yes. And then we need to set up a dedicated 40-minute cognitive assessment visit. And we'll go over that in the next talk. All right, so your patient, or their care partner are concerned about cognition. You need to set up a detailed cognitive assessment visit to really go through the history and figure out what's going on with this individual. And so how do you do that? Well, history is by far and away the most important puzzle piece in these complicated brain disorders that we're trying to solve. And the unique thing about cognitive and behavioral neurology and how to do this is you need someone else other than just the patient. I like to use the analogy. It's like, patients may forget examples of their memory difficulties, right? When we're dealing with Alzheimer's disease and related disorders, lack of insight into symptoms is a common thing. And so if you're relying only on that patient history, you're going to miss a lot of cases of cognitive impairment, especially early on. Now, your history has to be structured, so there has to be sort of a logical flow to it, but you need to be branching out and clarifying questions. Some examples, right? So, if they are no longer working, was this a planned retirement or was this due to cognitive changes? That would be important to know. If they're having troubles planning or organizing things, what are some examples? Listing those can help you get a sense of kind of the complete story of what's changing in this individual and give you some good concrete examples of that in your history. And then we also want to be evaluating for risk factors. Now, how to do this, how to actually walk through the smart form that we've created. Dr. Woodward will have her own video kind of going through this process for you. But from the larger scale side of things, just from the 1,000-foot view, we want to know that everyone is at risk for Alzheimer's disease, right? And the related disorders. So 10 to 15% of individuals will develop these disorders, with age being the biggest risk factor. So at each decade of life, especially after age 65, the numbers increase significantly. This also increases if they have a family history. So asking about a history of Alzheimer's disease or dementia or Lewy body disease or Parkinson's disease is important when you're taking that history, asking about the medicines, taking a look at those things, asking about sleep apnea. We're going to go through some of these in more detail when we talk about working up cognitive impairment, but be mindful of asking things about alcohol intake and how it can impact cognition, um, and things like traumatic brain injury as well. One of the key things you're going to want to try to figure out when you're taking this history is when did things start, right? So now in these disorders, it's not going to be like January 2nd of 2020 things started. It's usually going to be insidious. It's going to be gradual. It's going to be, well, actually thinking back, things have been going on for 1 year or 2 years or 5 years. We want to get a ballpark range of what's the timeline that we're dealing with. Um, and oftentimes these things are normal aging. We're not sure if they're abnormal or not, until a major life event happens that sort of unmasks what's been going on. I like to call these like cognitive stress tests. Here, I'll give you just a few examples of these. These are some of the ones we commonly see as sort of unmasking cognitive stress tests. And then what was the first symptom recognized? Was this a primary memory problem, or was behavior really the first thing that they noticed changing? Were word finding difficulties or language the first symptom? And these need to be obviously changes from their baseline. I want you to be thinking a little bit, and when you're asking questions, to be thinking in cognitive domains. So I'm not going to have time to go through all these, but I want these as sort of frameworks for you that can help you sort of think through which part of the brain might be involved, and which domain am I thinking in. So I list some memory and orientation questions, executive domain type questions, behavioral, especially when we're talking about personality. If you're thinking of like a behavioral variant frontotemporal dementia, language type of questions, visual spatial. And then we also have to think about the motor domain, especially when many patients might have Parkinson's as part of their, Parkinsonism as part of their syndrome. That can help us think of what's going on. A lot of people are visual learners, so here's a nice visual representation of those brain domains. This is a Wikipedia image, but basically it's color coded. So I color coded sort of where these map onto. When we think of behavior, it's usually on the right side of the brain, where language is usually on the left side of the brain. The back of the brain here being more visual spatial. So this will be a nice thing to reference. And then we also want to be asking about the progression of symptoms. So in most cases, symptoms are going to be progressive, and that's what brings the most concern. It's not like things just spontaneously got better. They wouldn't be, we wouldn't be doing this cognitive evaluation if that was the case. There can be sudden changes with other health problems. These are sort of like those cognitive stress tests, right? And you may see temporary improvement with either removing medicines that were contributing, treating the sleep apnea, replacing the B12, right? A lot of these reversible contributors, that's why we need to focus on those. But in the end, if this is Alzheimer's disease or a related disorder, we're going to see progressive neurologic decline. And this is due to a loss of synapses and neuronal death. And I could tell you about this, but I think really here, a picture is worth a thousand words. This is a patient that first came into our research center with mild cognitive impairment, very early changes in these memory structures. And this is a coronal image of an MRI. And then what I'm going to show you is a subsequent change over 6 to 7 years with multiple images. And you can really get an appreciation for what's occurring in the brain. This is a patient with Alzheimer's disease, and you start to see it was more on this right side, but certainly the left side being involved, where we're getting just a lot of atrophy over time. That is the nature of these diseases. We'll have a separate deeper dive talk on how to go through MRI images to sort of stage patients that way. But next, we're going to move on to doing the actual cognitive testing. All right, so we need to screen patients with good cognitive tools, right? So in order to do that, we're first going to want to do a focused neurologic exam. Now, know that in most patients presenting with early stages of Alzheimer's, their neurologic exam is going to be normal for the most part. But we do want to be on the lookout for signs of Parkinsonism. So think of this as sort of a focused, brief neurologic exam. And so things you might look out for is a rest tremor, especially when it's on one side more than the other. Slowness of movements. If your patient is really slow with all their movements, that's called bradykinesia. And you can do some finger tapping or foot tapping to also assess their movements. And then we also look for cogwheel rigidity, where we're kind of moving the arm around, feeling for cogwheeling, uh, hopefully with their muscles fully relaxed. And then you may notice decreased arm swing when they're walking, which may be a sign of that. And then a gait analysis, watching them walk. Are they hunched over in a stooped posture? Is this a new thing? Are they slow with shuffling steps? You may also want to just briefly assess where is there signs of stroke. So do they have weakness on one side or the other? That might indicate they had a stroke. And then when you're getting down to the part of the assessment where you need to screen them, part of this is just a simple plea to stop using the MMSE. It has a severe ceiling effect. So if you have an abnormal score, it can detect dementia, but it's not going to detect mild cognitive impairment very well. And one study was as low as 18%. So what we recommend for these better bedside screening tools, one being the Montreal Cognitive Assessment, which many around the country and world use, but it is now proprietary and requires some training. And then the St. Louis University mental status exam called the SLUMS is used sometimes here at the University of Kansas and the health systems. We use the short test of mental status, and so that's what I'll focus on. This test is similar to the other ones that you may have administered in the past, but it goes through these kind of brain different tests of orientation and attention and encoding information in the immediate recall, mental calculations, construction, information questions, and then ultimately coming back down to can they remember those 4 words with a delayed recall portion. This is out of 38 points, so it's not out of 30 like all the other tests. It is a test that is free to administer. Compared to the MOCA, it takes a little bit less time. There's a little bit better specificity for MCI. The MOCA is a little too sensitive in some cases. And compared to the MMSE, obviously much better about detecting. And SLUMS takes quite a bit more time, at least a couple minutes, which add up for each patient. Um, and then if you have a patient where, should I'm concerned about their cognition, should I refer them to neuropsychology? When to do that? The practicality is we can't refer everyone to neuropsychology. It does remain the gold standard, especially when things are early, these sort of very early on mild cognitive impairment cases. Neuropsych is the gold standard to make that diagnosis. If you have patients that have borderline normal screening tests, but there's still significant concern, some common scenarios is someone with high education background that can compensate pretty well on these sort of 10-minute screeners. We might need a lot more detailed testing that only neuropsychology can really offer. If you've got someone with mild cognitive impairment, Confirmation of that is important in many cases. And then determining the subtypes. Is this a amnestic or short-term memory subtype or non-amnestic? These are all potential reasons to refer to neuropsychology. We would not recommend it for folks that are testing or in the moderate dementia range, which we'll go into more detail in the staging portion. So we've got this patient that now has cognitive impairment. So what stage are they in? And I also will have a separate deeper dive talk on how to give the short test Mills test, especially for people that are just not familiar with the test, as long as some scoring tips. But with that, we will move on to staging. All right. So you have gone through a detailed history. You've done a cognitive um, testing assessment, and you've got this patient with cognitive impairment. How do you stage them appropriately? There's a framework for that, and so we'll walk through that. One of the things you'll go back to in your history taking is what changes are we seeing in the activities of daily living? That will help you with the staging. And of note, this needs to be a change from baseline, and ideally, you want some sort of evidence that this is due to a cognitive change, right? A behavioral change in the brain rather than some sort of limitation from physical limitation. Like, for example, if someone's no longer cleaning the house, because they've got severe arthritis and that limits their mobility, that's not an example that we're looking for here, right? Um, when we see these changes, we first ask about things like instrumental activities of daily living, which I give you some examples here. And then we also ask questions about the sort of basic activities of daily living that you see listed here. These can be sort of broken down in these different stages. And so there's actually a stage we have not talked about yet called subjective cognitive impairment. And this is when patients or families are noticing changes, but yet cognitive testing is entirely normal. You ideally would have pretty detailed testing, even neuropsychological testing, just showing that, yeah, we've done the full workup from the cognitive testing side and it looks normal. Um, this may be a patient going from the 90th percentile down to the 50th percentile, which is a major change for them, but it's just not at a level that we can detect yet from a cognitive impairment standpoint. When we call something mild cognitive impairment, this is where those tests are abnormal. We're seeing clear abnormalities on the cognitive testing, whether it be the screeners or ideally even more detailed testing. But patients are independent with their activities of daily living at this mild cognitive impairment stage. And then when we're calling something dementia, this is when someone is needing assistance with daily activities. And we can break that down into a little bit more detail. Here's a visual of this. So this just helps you sort of have this framework that you can reference. So when someone is noticing changes in their memory and it's quite concerning to them, but yet their cognitive testing is normal, we call this subjective cognitive impairment. And just like we talked about, that mild cognitive impairment really enters the equation once we have clear, objective cognitive abnormalities. And then dementia is once we're needing activities of daily living assistance. We can break that down a little bit further into sort of mild, moderate, and dementia stages. And in this mild stage, a good frame of reference for you is that patients are having trouble taking care of the world around them. So they might be having troubles managing their finances or managing medications or driving or shopping or preparing meals. Whereas moderate dementia is more of a stage where patients are starting to have trouble taking care of themselves. And they're starting to need assistance or dependence with things like dressing and bathing and grooming and these things of taking care of themselves. They'll be sleeping more in this stage. So families will comment on that. That can be a clue as well. And then in the more severe dementia cases, we're starting to lose the individual, meaning some of those major personality changes, basic functioning. They may need more assistance with transfers or feeding, or they may be having less conversation overall. And they may even be losing some of those long-term memories, what makes us, individuals. So we're starting to see that, and they may forget who their loved ones are, right? So there's a lot of changes at that severe dementia stage, and we're getting a lot more sleeping at that stage as well. Now, I'm going to give you these numbers. Everybody asks for them, so I'm going to give them to you. But this is obviously with a huge, caveat that we don't really recommend staging someone based on a cognitive screening test, especially something that's going to take you 10 minutes to do. but I'll give you some frames of reference and just know that so the STMS is out of 38 points, the MoCA is out of 30 points. These are ballpark ranges that usually match up with sort of that subjective history staging that we just went through. So for most patients that are in that subjective cognitive impairment range, the normal scores on the short test mental status and the MoCA are provided here. Whereas mild cognitive impairment scores, we're going to see them more in these ballpark ranges. And when we're seeing mild dementia, the scores are going to more match up in these ballpark ranges. And here's some ranges for moderate dementia and then severe dementia, where we're getting significantly low scores. So we have sort of staged an individual now, and then we really want to try to figure out what is the cause of this cognitive impairment. What's the cause of their mild cognitive impairment? What's the cause of their dementia? That's for the next talk. So we have detected cognitive impairment based on our cognitive assessment and the objective cognitive screening. And so now we need to properly work this up. And as you may well realize by now, these neurodegenerative brain diseases are complicated puzzles, and we need the detailed history, which comes from your cognitive assessment visit. We need an exam. We need imaging with preferably an MRI. We need lab tests, which we're going to talk about, and the cognitive testing. So when we think of reversible contributors, there's the obvious ones that we should be ruling out in everyone, B12 and thyroid, but we have to think about things like hearing and visual loss, medications that can contribute, which we'll talk about in a later series as well. The daily use, especially of anticholinergic agents, benzodiazepines can be associated with an increased risk of dementia. Untreated sleep apnea is one we often miss, so we have a low threshold for testing that. And then excessive alcohol intake can contribute to um, brain volume loss and risk of dementia, as well as stress, anxiety, depression. So I think it's best to think of it kind of like a tiered approach. The basic cognitive testing panel in everyone, sort of a tier one type of approach, should be a TSH, B12, CBC, complete metabolic panel. Most of these are done at your yearly visits, but B12 is often missed. So we shouldn't be diagnosing B12 deficiency in a tertiary care memory clinic. So that should just be part of the standard orders. Now, at what's coming, this 80 biomarker test, if somebody has clear objective cognitive impairment, it's going to be recommended that this gets implemented in your workflow. And so there's actually a whole series that Dr. Burns goes over that'll be tied to this as far as ordering recommendations and interpretation of results. For imaging, an MRI without gadolinium can help with that time window of getting an MRI done more efficiently. Not everyone needs contrast. Um, a non-contrast head CT scan can be done if an MRI is completely contraindicated. If someone is extremely claustrophobic or is like, I can't handle an MRI, we do not recommend anesthesia. The risk outweighs the benefit there of obtaining high quality imaging. If they're mildly claustrophobic or anxious, a low dose of lorazepam can be helpful there. But you would want to have them have someone drive them with the sedation effect there. For advanced cognitive testing, here's a panel of things to consider, especially with risk factors, including RPR and HIV. Sleep study, again, low threshold for this. If you are getting any indication of snoring from the bed partner, usually has to come from the bed partner, or daytime sleepiness, then we have a very low threshold to recommend a sleep study because that could be the primary contributor to the cognitive impairment, and it could increase the risk of developing dementia over time if untreated. And then as far as brain MRI with gadolinium contrast, that would be in rapid onset cases, unusual symptoms, autoimmune concerns, or a history of cancer, because we need contrast to help look for that in the brain. Uh, FDG PET scans, these are typically going to be ordered by specialists like myself, but we do see primary care docs and general neurologists order these. They should really only be ordered if the dementia diagnosis is not clear despite the typical workup. And it can really help with that differential specific dementia diagnosis. The reads of these, especially at non-academic centers, are usually not accurate, and they're sometimes not accurate at our own center. So keep that in mind when ordering these. It might need to be interpreted by a specialist. As far as other neuro, tests, these are usually ordered by neurologists. We think of like a lumbar puncture. Again, some reasons for that include rapid onset autoimmune. We can also do spinal fluid analysis with 80 biomarkers. You can do an autoimmune panel as well when it fits the clinical scenario. Amyloid PET scans, these are usually if the biomarker fluid testing is either inconclusive or contraindicated. EEGs, again, if there's potential for seizures. A DAT scan can help for differentiation of sort of a Parkinson's disease or tremor etiology. And then we do have a skin biopsy that we do regularly in our memory clinic that can help with biomarker confirmation of these alpha-synuclein diseases. We'll have a link for a deeper dive with a pocket talk related to this in below. All right, so we have determined the stage of this individual's cognitive impairment. Now we really want to try to define the clinical syndrome. So you're going to be utilizing all these puzzle pieces we've gathered in the history and the cognitive testing and maybe the brain imaging or the other tests to really try to characterize this. Of note, we still have to keep in mind the reversible factors, right? Because these could be contributing 10% or 50% of the cause of the changes. So those must be addressed. But of these neurodegenerative causes, there's typically amnestic cognitive impairment syndromes where it starts as short-term memory. That's by far and away the most common thing you'll see, and that's typical Alzheimer's disease. There's a mimicker that we're not going to talk about in detail through these talks. And then there's the non-amnestic type, which is more of your Lewy body, frontotemporal disease, and vascular disease, and some of the variants of Alzheimer's. As far as percentages, right? If you were to flip a coin, you'd be right half the time calling it Alzheimer's because that's over half of the cases, but this gives you a decent breakdown. I lump Parkinson's disease, dementia, and dementia with Lewy bodies together in most cases, and that ultimately is the second most common cause at about 20%, with frontotemporal dementia being much less common. However, it's more complicated than that, and the reality is that mixed pathologies is more common than anything by itself, but we can usually determine which one's driving the ship based on a thorough investigation. When we think about this differential, Alzheimer's disease is typically this memory impairment, repeating questions, forgetting appointments. We see shrinkage in the memory structures. This is what a glucose PET scan might look like. Vascular disease is really reliant on brain MRI imaging, ideally, sometimes CTs, but the history might include a history of strokes or the severe white matter disease we might see. Whereas Lewy body disease has four cardinal features that we're really looking for, and frontotemporal disease kind of has its own cardinal features that we're looking for. A progressive amnestic syndrome, most commonly is Alzheimer's disease. These are folks that even if they do have some co-pathology, we can pretty much determine that Alzheimer's still seems to be the primary. You may get a progressive amnestic syndrome in somebody with Alzheimer's biomarkers that come back negative. And in that case, we might be thinking about something called late disease, which is a mimicker. These can show up as a single domain, like single memory domain impairment, where they're really struggling with learning new information. Navigational difficulties may also be present. And this is because there's dysfunction in the medial temporal lobe that we can see on a coronal MRI image. So especially when we reach sort of shrinkage of these memory structures that look like these bottom images, that's where we start to see significant memory problems. And then you can get other domains involved, especially as the disease spreads to other parts of the brain. So this is where we might start to get executive and language and visuospatial and behavior dysfunction. So we call that multi-domain impairment. But certainly when memory is involved, we still are thinking Alzheimer's as the primary. And again, this rate represents over half of what you will see in the real world out there. And then when we think of things like blood markers, this is really going to help our diagnostic confidence that this is the underlying etiology of this syndrome. When we think of progressive cognitive Parkinsonism syndromes, the most common etiology is Lewy body disease, and I lump that together again with those two, DLB and PDD. These patients usually have multi-domain impairment with executive, visuospatial, attention, and memory being involved. This is due to the back part of the brain being the predominant things. You might find the MRI is normal. So we might not see the shrinkage like we see in Alzheimer's disease on MRI. So actually a normal MRI, especially in the setting of all these other constellation of things can be a helpful, at least supportive tool. We look really for 4 clinical features. A patient needs to have 2 out of 4 of these. So we look for significant fluctuations in cognition and alertness. Usually a care partner is the only one that's going to be able to tell you about that, someone that knows them well. And then recurrent visual hallucinations. Patients usually can recall these, so asking them, but also asking the care partner. They can start as more benign, shadowy figures or feelings of presence, but to meet the criteria, they need these sort of recurrent visual hallucinations. And then REM, sleep behavior disorder, which is acting out dreams at nighttime, you're going to have to ask a bed partner. You can't, the patient's going to have no idea they're sleeping, right? And then extrapyramidal symptoms are those Parkinsonism symptoms that we've talked about in a previous talk. So what about primary vascular disease? You're going to read in every single MRI report you get that there's mild, chronic, small vessel disease. Sometimes it's moderate. The mild cases are not a vascular etiology. Now, you can have small amounts of vascular disease that really affects memory in different ways, and they could be just strategic strokes within the memory pathway. So I give 2 examples here. And then you may have severe vascular disease where it's just a bunch of small silent strokes adding up to contribute. And then there's another condition called cerebral amyloid angiopathy where we get lots of microbleeds in the brain, and that can lead to vascular disease. Um, as far as deeper dives, there's a lot of other progressive syndromes that I would like to convey to you, but those are less common and not the focus of these bite-sized talks. So we'll have a separate talk on that, as well as going through neuroimaging, especially MRI and FDG PET scans. So now that we've kind of determined the stage and the underlying etiology, we need to schedule a diagnostic visit to discuss these results and to deliver a diagnosis. All right, you have helped a patient down this journey of figuring out the stage and the cause of their underlying cognitive disorder. And now we need to meet back with them in a diagnostic disclosure visit to deliver that diagnosis. And just to reiterate some of the importance of a disclosure. So, most Americans have said that they want to know what's causing their symptoms. We shouldn't have gone down the road of testing and working someone up if they didn't want to know this in the first place, right? So, most people want to know. There are some that don't, and you shouldn't do this whole process if they don't want to know, right? But most people do. Most people are seeking an explanation for their symptoms. They need a name to call this, right? They need to know what's happening to them. They need to plan. They need to be thinking about long-term things. They might need medication oversight, right? There's lots of reasons why a diagnosis is important. According to a study through the Alzheimer's Association, less than half of patients are told that they have dementia by their provider. They might be on medicines even for dementia, but have no idea why they're on them. As far as some recommendations, so there's many that are out there, but I think these are some kind of essential ones. So, you have to disclose the diagnosis. That's an essential part of like doing this whole workup in the first place, right? Um, and patients and families want to know what stage are we in, what's the cause, what are the multiple causes, right? What's the primary cause? Um, and we need to explain the patient's disease accurately and compassionately. So I'll give you some tips on that. One tip is planning enough time, right? You can't just plan a 5-minute visit and say you've got Alzheimer's disease. I'm sorry, there's nothing we can do. I can't tell you how many times I've heard that story, right? And oftentimes that's not the full reality, but that's how the patients and families perceived it, which is not ideal. I mean, these are life-altering diagnoses, and there's going to be questions. There's going to be questions that you can't fully answer, but things that we need to explore at future visits. Um, the care partners are essential in this, right? Because the nature of what we're dealing with, patients are usually unable to explain their diagnosis in detail shortly after disclosure. There's the shock value of it. We see that in the cancer diagnosis world as well, but we're also dealing with cognitive changes. They may not even have full capacity to sort of fully understand all these things. And the care partners are going to be essential in planning all the things that we're going to need to do as far as oversight of things, depending on the stage that we're in. We want patient-centered communication. You don't deliver the diagnosis to the family member. You're delivering the diagnosis to the patient, but the family member is present, right? And sometimes it's multiple family members in our case in the memory clinic. You don't want to lead with the diagnosis. I mean, that's just delivering bad news one-on-one. you want to set the stage, right? We're meeting back to review tests to help understand what's been driving some of these changes. You do want to explore the patient's perspective. So why do they think things are changing? Do they have unrealistic expectations? Do they have a pretty good sense of what's going on? What is their insight? Um, Hearing from them, sort of gathering that information is important, and you're sort of building that lead up. And then you want to create confidence in the workup, right? So we go through the tests. You had an MRI done, you had a sleep study done, you had cognitive testing done, and we walked through those. You had certain blood tests done. So we ruled out these things, right? Now, I really do think these blood biomarkers are going to be game changers to help, especially clinicians, for that diagnostic confidence and for the patients they're seeing. And then when you're delivering this, obviously this is going to be a really difficult conversation. You're going to have to respond with empathy, right? There's many times where I tell patients and family members, I'm sorry, I don't have better news to share with you, right? There's another example. And we need to offer support, right? So reminding them that we started this journey trying to figure out what is causing your symptoms. You're still the same person now as you were before you walked in and received this diagnosis. We just have a name to it. We know now what is going on, and then we can plan, plan basically to work together and how you can live well with this diagnosis. Um, One of the big things is kind of what happens after a diagnosis. We need better tools in our toolbox. And one of those things is a care navigator, right? This happens all the time in the cancer world. We have a model that we've worked with in our memory clinic that, ideally we're training other sort of like a spoken hub model of other care navigators in other clinics, a social worker, a nurse designated in your clinic. We need better disease education. We need support services. We need to be mindful of some of those concerns that are going to come up as these disease progress and planning things. It's much better to be proactive about things rather than reactive after something bad has happened. You're going to need to plan a follow-up, right? There's going to be things that we need to be thinking about from an advanced directive and care planning perspective. And then ultimately, when we make a diagnosis, we need a plan. And so, what are some of those treatment options? What are those lifestyle recommendations? We'll talk about that through the next set of talks. For medications that can help out cognition in these disorders, we have a list of ones, but I first want to just mention kind of the hypothesis and the theory behind this. So, patients with both Alzheimer's disease and Lewy body disease are having decreases in acetylcholine, which really projects out to the brain. That helps with a lot of our memory and thinking. And so this specific region, this green blob here, is the nucleus basalis minor. And we know that neurons here undergo a lot of damage in these diseases. And so basically what we're trying to do is supplement acetylcholine or the cholinergic system in the brain with these medications. It also highlights why the anticholinergic burden is a big deal, because if we have a patient with lower acetylcholine and then you block it further, that's going to cause even worsening of symptoms. And so I list a couple of here. You can go to this acbcalc.com and type in common medications that are prescribed for various reasons and see what the burden is for your patient if you're unsure. So should my patient be on one of these drugs that keeps acetylcholine around longer? For a patient with Lewy body disease, that answer is absolutely yes. Especially if they have MCI or dementia. For Alzheimer's disease, dementia, the answer to that is emphatically yes as well. We see it work a little bit better in the younger onset dysexecutive variants, but both short-term data and long-term data supports the use of these medications as first-line agents. For folks with mild cognitive impairment due to probable Alzheimer's disease, I have to put off-label and probably. However, if you have a patient where you're sure that their mild cognitive impairment is at least in part due to early Alzheimer's, it doesn't make sense to wait until dementia to start it. But if you have somebody that has mild cognitive impairment due to sleep apnea as the primary cause, starting this medicine is not going to help with that. So you do want to have some sort of evidence of Alzheimer's disease if you're going to be starting it. For vascular disease, I put probably not. However, when we talked earlier about co-pathology, Alzheimer's and Lewy body can run together with vascular. So if I had any inkling that those were also going on, I would consider it. Whereas frontotemporal disease is not recommended. Um, So some tips on this. We always start with donepezil. I'll give you a few reasons why. We always start at a low dose and we titrate up slowly over at a minimum of 1 month. If they're doing fine at 5 and then once you go to 10, they have GI problems, then try splitting the dose to where that peak effect in the blood system isn't causing the symptoms as much. We do go higher than the standard doses, but that's in limited cases, specifically in patients that can tolerate it, like in Lewy body disease or young onset Alzheimer's. There is a 23 milligram tablet you should be aware of out there. We don't really ever prescribe it due to cost, but the bioavailability of 10 twice a day is very similar. Galantamine oral is especially the extended release version we'll use as second line after donepezil. And then there's the rivastigmine patch that we use commonly if folks are having GI issues. Um, I like this graph as a reason why I never prescribe rivastigmine oral. It has a high peak concentration, which drives a lot of the side effects, and then you have to give it twice a day, whereas the patch has a nice pharmacokinetics and dynamics. Here's some tips for skin care that you can reference later for the patch. When we think about side effects, the main one is diarrhea, nausea, vomiting, basically GI side effects. I like to explain this to patients as to why. It's helpful to keep in your head. Acetylcholine helps you digest food. So whenever you eat food, it naturally gets released to help with peristalsis and digestion. And we're just basically supplementing that. So if you take this on an empty stomach, it's very likely to cause these symptoms. It's why it has traditionally been suggested to prescribe at nighttime. But if you take it with a high protein meal, that can help offset some of those side effects. Here's the general percentages of these side effects with each one, and another reason why we just don't prescribe rivastigmine oral. Muscle cramps are more common with Nepozil, but not as common with galantamine and rivastigmine patch, so a potential reason to switch. Nightmares and insomnia can be seen even when given at the daytime, but they're much more common if you prescribe this at nighttime. The heart is something we have to think about. Sometimes your clues could be lightheadedness or fatigue. Um, we might have patients that have baseline bradycardia or heart block or prolonged QTC, especially if they're on other prolonging agents. So tracking things with an EKG may be recommended, and then potentially less with the galantamine or rivastigmine. Should I start memantine? Well, not as an initial primary medication. It's an adjunct agent at the moderate to severe stages, and it may help with some of the behavioral symptoms. There's some mild synergistic effect based on clinical studies, but not in the milder stages. And any benefit is very mild on the cognitive side of things. Sometimes it worsens neuropsychiatric symptoms in Lewy body disease. Sometimes it helps. There's conflicting evidence there. FTD, there's been no benefit. There is a combo drug that has donepezil and memantine in it if pill burden is an issue. Here's just a nice graph for you to think this through. So when you have a patient with mild cognitive impairment and dementia, you want to be initiating these cholinesterase inhibitors for that cholinergic reason, and that can help boost their diminishing cholinergic system to help sort of slow down the symptom progression. The ultimately they're still going to reach moderate dementia stages, and that's where we're thinking about initiating memantine. I do also put here in this blue column, this is where you should be considering the anti-amyloid therapies, lecanemab and donanemab. Um, I'm going to do a whole other talk on the anti-amyloid agents as far as risk benefits, qualifications, what it looks like at a practical level. But just know that if you think your patient might be eligible, we have a subclinic within our memory clinic that does this evaluation that helps determine eligibility. So I list some of these eligibilities here. They obviously have to be biomarker positive to try to target the amyloid plaques. And then we'll also do ApoE genotyping, which helps with that risk benefit discussion. And then we help facilitate the IV infusions in the scheduling monitoring program with MRIs. But this is not a comprehensive treatment clinic. This is specifically designed for your anti-amyloid treatment clinic folks. For behavioral symptom management, there are a number of options, and it's important to first note how common are these. So depending on your definition, it's upwards of 99% of individuals with dementia and related disorders will develop neuropsychiatric symptoms. This results in more rapid cognitive decline when we see it. It results in earlier institutionalization, as well as higher healthcare costs. And we see a lot of caregiver burden and depression related to these symptoms specifically. Here's a breakdown of the different neurodegenerative syndromes on the left side, and then the neuropsychiatric symptoms going across each syndrome. And you'll note that apathy is present in everyone. Depression is extremely common, whereas disinhibition and impulsiveness are more commonly seen in our frontotemporal disorders, whereas delusions and hallucinations more in the Alzheimer's and Lewy body categories. As far as when do these symptoms show up in the disease process, this dotted line is the time of diagnosis, whereas we have many symptoms that are emerging months and months before diagnosis, and then symptoms that tend to come after. You see how common agitation is. I'm not going to have time to go through this in detail, but this is for your reference as far as frequency and timing. There is no certain algorithm for every patient, but just keep in mind every case is unique. Oftentimes, finding that trigger and avoiding the trigger is more important than just throwing a medicine at it. The medicine should be reserved more for when those non-pharmacologic strategies are not working, or when an individual is a threat to themselves or others. We always want to try to avoid the emergency level of these symptoms, so starting them early on in the disease course and starting at low doses and going up slowly is recommended. Our goal is really to avoid these emergencies. Um, Depression often goes unrecognized, especially when you use good validated tools like the PHQ-9s. The problem here is the patient often has a poor insight into their symptoms, or the depression is emerging as a different phenotype, whereas anxiety might be the main thing, or irritability. When you see variable mood throughout the day, especially with excessive irritability, depression is often the trigger. Um, SSRI medications can help with this. SNRI2 really for more of like a melancholic depression, but note that it might worsen agitation and irritability in these diseases with that norepinephrine component. For anxiety, it can show up in a lot of different ways. Oftentimes, it's obsessive thoughts and compulsions. It's irritability, it's agitation. Uh, the first line treatment for this are SSRIs with good anti-anxiolytic properties. So usually escitalopram or sertraline are our first two choices there. And SNRIs can sometimes have too much of an activating effect in anxiety in these folks. For as needed kind of adjuncts, low doses of trazodone and buspirone can be utilized. There are some cases, even in our specialty memory clinic, where we've tried everything, and benzodiazepines are the only thing that helps with like very severe anxiety. But there's a lot of risks with those, and oftentimes the risks outweigh the benefits. For agitation and aggression, so there's lots of different non-pharmacologic strategies, which I'm not going to go through the details of. I'm just going to have these where you can pause and you can reference these. But there is a new medicine that is approved for agitation, specifically due or related to Alzheimer's disease, and this is called brexpiprazole or Rexulti. The reason we don't prescribe this in everyone is cost, but if you prescribe it as with the indication Alzheimer's disease with agitation, you can potentially get this approved through a prior approval process. There is an older cousin of this called aripiprazole. It's dirtier, meaning it might have more side effects, especially Parkinsonism. Um, but it's also much cheaper, so it's a reasonable one to start, especially in patients that have pretty clear Alzheimer's agitation. For apathy, having a plan for the day, a structured, tailored activities program is the number one treatment for apathy because it's just universal. There's not great treatments for this. There is a study looking at methylphenidate, and this had notable decreases in apathy scores in the first 3 months, lasting throughout the 6 months of the study. You do run a small risk of worsening some behaviors. And then modafinil we'll use in Lewy body disease for attention and daytime sleepiness, and it might have a benefit in the apathy side as well. So I told you no algorithm here, but I do want to have this for your reference. So, step one is really to remove any contributing medications or pain. So, the different versions of this we've talked about in our workup of cognitive changes. Um, we want to initiate donepezil and memantine, especially in patients with Alzheimer's and Lewy body disease, but you would skip this step, obviously, in frontotemporal disease. Um, Sleep optimization is important. So many patients have sleep fragmentation, they have untreated sleep apnea, they have other insomnia-related sleep disorders that need to be treated. We typically recommend melatonin and trazodone as our two main therapies. The new orexin modulators might be helpful, but I'm usually getting a sleep consult if I'm considering those. And then starting with an SSRI, starting low, going slow. We prefer escitalopram and sertraline. We do not use paroxetine in Alzheimer's or Lewy body because it does have some anticholinergic properties. And then when we think of antipsychotics, again, starting low and going slow, quetiapine won't generally worsen Parkinson's, so it's nice to use in our Lewy body or Parkinson's patients. Brexpiprazole is newly approved and has less Parkinsonism than its cousin. Risperidone can be used for more of Alzheimer's related cases. And then pimavanserin can really help in hallucinations related to Lewy body. As far as lifestyle recommendations, there are a number that we recommend for brain health. Um, One of the goals of these is to really increase one's cognitive reserve. So you could think of the brain's cognitive reserve and all these different aspects of psychosocial stimulation to increase cognitive reserve. I use the analogy of even if you have these plaques and tangles building up in the brain that represent Alzheimer's disease, do you have routes around that traffic, right? And that's what the cognitive reserve aspect taps into. As far as physical activity, we recommend more movement. Sitting is the new smoking. So there are lots of ways that you can sort of reduce and break up sedentary time with different techniques. Now, for your patients that are getting pretty good physical activity, are they getting enough exercise? And I like to break that down where exercise is really more of movement that is planned or structured to improve your fitness level. And there's different tiers of exercise here. Aerobic exercise is really what we're shooting for. That's the what the National Institutes of Aging recommends 150 minutes a week of, broken down in different time allotments. We usually recommend an exercise bike for that because it allows you to push that heart rate up without stressing out the joints or risk of falling. And just note that the higher one's cardiorespiratory fitness is, especially at midlife, it sort of delays the onset of dementia by up to 7 years. And we also see higher intensity exercise push that brain-derived neurotrophic factor, which I describe as sort of fertilizer for those brain cells. Sleep is important. We need to be getting the right amount of sleep, but also it's not just quantity, it's the right quality of sleep. So you need to be ruling out sleep apnea in many cases if sleep is an issue. There's also insomnia, and then there's REM sleep behavior disorder. We typically use melatonin and clonazepam for that sleep issue. And then you may need a sleep consultation if your typical insomnia meds are not doing the trick. So what does sleep have to do with it? We know there's a bidirectional effect with sleep apnea and Alzheimer's disease. So when we see patients diagnosed with Alzheimer's disease, they're at much higher risk of fragmented sleep and less slow wave sleep, and also increased amount of sleep apnea frequency. And this is associated with increased amyloid plaque loads in the brain due to decreased amyloid clearance. And then there's been studies looking at untreated sleep apnea progressing to dementia faster in patients with mild cognitive impairment. Diet is important as well. We recommend the Mediterranean or a version of that called the Mind diet. Um, but there are ongoing studies on the ketogenic diet. We have one here at KU right now. And then there's other groups looking at intermittent fasting, caloric restriction. This sort of ketosis idea may allow sort of clearance of the dysfunctional mitochondria, but needs to be tested further. For cognitive and social activity, should I be doing brain games? We get asked that question a lot. Um, these may have limited real world benefit, but they aren't necessarily harmful either if you're sort of limiting, doing it sort of like you would exercise 30 to 60 minutes a day. You're not just doing that for hours on end of the day to where you're isolated on an iPad. We want a diverse cognitive diet, not the same thing every day. So the more important to do novel things, engaging in that community. These types of things are going to utilize your brain. I like the saying of a conversation with a friend over lunch is going to use your brain as much as any brain game is going to throw at you. But obviously, the diverseness of that matters. We have a whole LEAP program that goes through all these, and these can be offered through Zoom courses as well as the Brain Health Boot Camp that we offer, which is sort of a 6-week program. And then there's also a Mediterranean diet course, and your patients can visit our LEAP program to sign up for that. All right, with this last talk, I want to just briefly mention some of the common challenges in dementia care and progression. Getting that diagnosis established is one of the hardest parts, but then what happens after a diagnosis is oftentimes another shortcoming in our field. So there's a lot of different things listed here that I'll let you review, but to summarize, there's a lot of lack of information of where to find resources, what research studies are involved, what should we be doing, what are the next steps, how, as a care partner, do I receive support and training to help care for this individual with time. My biggest frustration as a cognitive specialist is those lack of predictors on speed of progression. And then we'll have a slide at the end on this anticipatory grief. Um, from a care navigation standpoint, these are important to incorporate at that point of diagnosis, not when a crisis occurs. And so having someone in your clinic, whether it be a nurse or a social worker, that helps as that care navigator to help with these education, accessing resources, and earlier interventions are key. And our motto is to be proactive, not reactive to these things. We cannot operate on the current crisis mode intervention model. That's what leads to hospitalizations and worse outcomes. Our cognitive care network is who helps operate our care navigator system, and they partner with other primary care clinics. So contact Michelle Needens to help get integrated into that, and they help train your care navigator to be dementia capable and ready. And there is a Medicare guide model out there. We don't currently use it, but it is a great model, and you'll see in every single one of those models it involves a care navigator. Brain changes bear challenges, right? So we know that as the brain changes, symptoms progress, and some of this involves with what parts of the brain are changing of what symptoms we see. When the right side of the brain, especially in the anterior temporal lobe, is involved, we see a lot of anosognosia, which is just a lack of insight into symptoms. We can see executive dysfunction. And then in the medial temporal lobe, we've talked about that's where those short-term memory structures are. So even if someone agrees to it's probably time to stop driving with a really detailed conversation, will they remember that 30 minutes later, at least what was agreed upon, the details of it, right? And this raises many questions about decision-making capacity, driving, independence, and safety. And even if they're okay right now, these are things that need to be reevaluated over time. Driving is one of the most complicated and you know contentious discussions we have in these diseases. I do preface this usually with even if you're safe to drive now, it's not a matter of if but when. Having that conversation early can be helpful. The Alzheimer's Association does have a driving contract you can consider if that works for your clinic model. And then I really do want family members to be riding with this individual because that's one of the limitations I have when seeing them in person. I can have my concerns, but if everyone riding with them is not concerned, then, I think they need to closely monitor. But if there's ever a gray zone where we're just not sure, or I'm super concerned, they're not, or vice versa, getting a driving, an objective driving evaluation is recommended. And that's kind of the gold standard here. I have a whole pocket talk on this driving discussion that we'll link in the description below this video. As far as medications and medical oversight, um, it's important to start to incorporate these external memory aids with a pill box, but with some oversight and making sure that things are being taken appropriately. Um, and then properly managing these chronic diseases with the medications they're on can help avoid these hospitalizations and crises, like I talked about, avoiding the potential delirium and helping slow down the progression, especially when you're managing these vascular risk factors well. And then starting that advanced care planning, right? Getting durable power of attorney, getting the financial and healthcare aspects of that in place are important. For the financial side of things, oversight with bills is usually needed. We see examples of both ways, overpaying, underpaying. Um, Auto pay can help here, but again, some sort of oversight is probably necessary just to make sure that the process is working appropriately. And then there's the scams that this can be due to either memory problems like repeated well-meaning donations or scams due to judgment problems. Um, and you can do things to try to help mitigate some of this risk, but you usually need some sort of financial POA, or at least depending on the patient's insight and ability. And that usually requires us to document the cognitive impairment, the stage that someone's in, which is all part of the previous talks, and then activating the financial POA. Lastly, I just want to briefly mention anticipatory grief. So that can involve both the care partners and patients, and it's much higher in those that have a family history. The anticipating the loss, right? The stage of dementia that comes after where we're currently at, and really refocusing on that present. That can be very helpful for both patient and care partner. Um, and recognizing that even if they have a family history, right, not everyone's journey with this disease is the same. Not everyone progresses at the same rates. Not everyone develops the same symptoms. Everyone's unique with this. But what is very common across almost all patients is some amount of depression, and recognizing and treating is important with medications, but also the non-pharmacologic options that are listed here.
Alzheimer's blood biomarkers are a groundbreaking advance, changing the landscape of dementia care by enhancing our ability to detect the disease early, guide our choice of new therapies, and provide a more confident diagnosis. It's essential to use these measures for the right patients, older adults with clinically significant cognitive changes. In the early stages of disease, misdiagnosis rates can reach 30 to 50%. What do I mean by clinically significant? A detailed clinical history that demonstrates clear cognitive changes that persist over time. It's particularly helpful if that history is corroborated by family members and in-office cognitive tests that objectively support some level of change, even if mild. For instance, take note when a patient or their family members report persistent memory lapses, such as forgetting conversations or frequently repeating questions. Difficulty managing finances or organizing daily tasks, especially when these challenges persist over time, can also indicate significant cognitive change. Imagine a patient who frequently forgets conversations and struggles with daily tasks. If these issues persist and are confirmed by family and cognitive tests, this patient is an excellent candidate for blood biomarker testing. It's this group of patients, those who exhibit clear, documented signs of cognitive decline, who stand to benefit the most from these advanced diagnostics. There are important limitations. As of now, we do not recommend these tests for individuals without evident cognitive change. The aim is not to predict Alzheimer's risk in asymptomatic individuals or to inform prevention strategies. That is still confined to the research realm. Instead, the focus remains on those already experiencing cognitive symptoms, reducing the risk of false or misleading results. By carefully selecting patients for blood-based biomarker testing based on well-documented cognitive changes, we enhance our ability to recognize and diagnose Alzheimer's changes early and proactively manage them. Interpreting Alzheimer's blood biomarkers is a crucial skill that can significantly impact patient care by enabling early detection, guiding interventions, and providing a more confident diagnosis. Alzheimer's blood measures offer a window into the brain and can be used to guide early detection and intervention when used in patients with significant cognitive changes. Remember, these blood measures reflect the likelihood of the presence of amyloid in the brain. The tests alone are not diagnostic, but they indicate the probability that amyloid, a hallmark of Alzheimer's, is present in the brain. What is amyloid? Amyloid is a key protein found in the brains of people with Alzheimer's disease. In a patient with documented cognitive decline, the detection of amyloid raises the likelihood that Alzheimer's is the cause. Interpreting a result varies with each patient, depending on their clinical history, the extent of cognitive impairment that's documented, and the blood measure value. For patients with well-documented dementia and clearly elevated amyloid, Alzheimer's is essentially confirmed. Proceeding with an Alzheimer's treatment strategy is the most reasonable path forward. There are now a number of disease-modifying therapies that have been approved by the FDA. On the other hand, patients with questionable cognitive symptoms require a more cautious approach, and you may want to observe them over time before ordering blood tests. For patients whose blood tests are indeterminate, near the cut point, we have less confidence in the accuracy. In these cases, consider gold standard tests like an amyloid PET scan to visually confirm the presence of amyloid, or a lumbar puncture to analyze the cerebrospinal fluid. This can offer a higher sensitivity and specificity for detecting Alzheimer's pathology. In cases where Alzheimer's biomarkers are absent or negative, explore other potential causes for cognitive decline, such as depression or medication effects or sleep apnea. Interpreting blood-based biomarkers for Alzheimer's demands a blend of science and clinical judgment to navigate the complexities of diagnosis and treatment with greater confidence and precision. A few things to consider. Did you know that 25% of older adults without memory problems have elevated amyloid? Amyloid alone does not cause dementia, but when it's observed in the context of cognitive decline, it greatly increases the likelihood of Alzheimer's. This is why it's important to test patients with confirmed cognitive decline. Also, recognize that false positives and false negatives are possible. Blood tests are not as good as lumbar puncture or PET scans, but overall have good sensitivity and specificity, so clinical context remains very important. Blood biomarkers are a revolutionary tool in Alzheimer's care, offering a less invasive and more accessible way to diagnose the disease earlier and more accurately. These biomarkers can simplify the diagnostic process. By detecting the presence or absence of amyloid, a protein that accumulates in Alzheimer's patients, these tests help you identify the underlying cause of cognitive decline, enhance the confidence of your diagnosis, and can open the door for pursuing new therapies aimed at reducing brain amyloid in patients with mild cognitive impairment and early Alzheimer's disease. In patients presenting with cognitive decline, these biomarkers can help distinguish Alzheimer's from other forms of dementia, such as frontotemporal dementia or Lewy body dementia. This differentiation is crucial for tailoring appropriate treatment plans and managing patient care effectively. In cases with an absence of Alzheimer's biomarkers, we should explore other potential causes for cognitive decline, such as vascular injury from stroke on MRI, depression, sleep apnea, and medication side effects. For instance, consider a patient with persistent memory or cognitive changes. If their blood test indicates a high likelihood of elevated amyloid in the brain, you can start discussing the potential for anti-amyloid therapies and consider a referral for those therapies. Early diagnosis empowers your patients and their families. It gives them the information they need to make informed decisions about their future care. Explore lifestyle modifications, and potentially participate in clinical trials that could benefit them and future generations. By reducing diagnostic uncertainty and providing a clearer picture of the underlying disease process, blood biomarkers can significantly enhance your ability to help patients navigate the challenges of Alzheimer's disease. So in summary, blood biomarkers are transformative tools in Alzheimer's care, offering early detection, aiding differential diagnosis, monitoring disease progression, and supporting personalized treatment strategies. By integrating these biomarkers into your clinical practice, you can greatly improve the management and care of patients with Alzheimer's disease. Effectively communicating the results of Alzheimer's blood biomarkers is important for guiding diagnosis and treatment, and for providing patients with clear and actionable information. Interpreting Alzheimer's blood tests results starts with understanding what the test shows, the likelihood of amyloid protein in the brain. The result alone is not a diagnosis of Alzheimer's. It indicates whether amyloid is likely present, a positive result, unlikely to be present, a negative result, or unclear, an indeterminate result. So let's go through each of these scenarios. A positive result for amyloid suggests that a key component of Alzheimer's pathology, amyloid buildup, is present in the brain. This is important because when it aligns with progressive and persistent cognitive issues, it's consistent with the diagnosis of Alzheimer's disease as the cause of mild cognitive impairment or dementia. Naming the symptoms helps us understand their cause and determine the next steps. The path forward is now clear, and it's important to establish both a therapeutic plan and an action plan for the patient. Providing information on support groups, educational materials, and other resources can help patients and their families take a proactive approach. If the test is negative for amyloid, reassure the patient that this is good news, though it doesn't mean they aren't experiencing cognitive issues. Explain that further investigation or observation may be needed to identify the underlying issues. We should now consider other potential causes, such as vascular changes, sleep apnea, medications, or depression and anxiety. If a test is indeterminate, it means we don't have enough precision to be confident either way. If clinical suspicion of progressive cognitive decline is strong, consider more precise tests, such as a lumbar puncture for Alzheimer's biomarkers or an amyloid PET scan. Alternatively, we may need to observe for changes over time and repeat testing later to reach a more definitive conclusion. So in summary, effective communication of Alzheimer's blood biomarker results involves explaining the results, discussing their implications, addressing patient concerns, and providing support and resources. By approaching this conversation with empathy and clarity, we help patients understand their condition and empower them to make informed decisions about their care. While blood biomarkers offer a valuable tool for Alzheimer's assessment, it's crucial to understand their limits. First, blood tests are not a standalone diagnostic tool. They must be interpreted in the context of the patient's clinical history. It's important to use these tests on patients who are likely to have Alzheimer's disease, generally older adults, usually over the age of 55, with a history of clinically significant, consistent, and persistent cognitive issues. Testing in the most appropriate patients enhances the precision of these tests and their predictive value. We are not yet ready to use these tests in patients without documented cognitive issues, such as those concerned about a family history or wanting to understand their long-term risk. Did you know that 25% of older adults without memory problems have elevated brain amyloid? What it means to have amyloid in someone without cognitive issues and what we can do about it remains a topic confined to the research arena. For now, it's important to only test patients with confirmed cognitive decline. Second, like any medical test, there's a potential for false positives and false negatives, especially in cases where amyloid levels are near the cutoff point. Additionally, we have much to learn about how comorbid conditions such as kidney disease can influence the results. We know that someone with reduced kidney function can have falsely elevated results, so this should be an important consideration when interpreting results. Third, blood tests may not be sensitive enough to detect amyloid elevation in the very early stages of Alzheimer's disease. This means that a negative result doesn't rule out the possibility of early-stage Alzheimer's, and follow-up testing may be necessary. By understanding the limitations of blood biomarkers, you can use them appropriately and effectively in your clinical practice. They are a valuable addition to your diagnostic toolbox and should be used to augment, but not replace, careful clinical judgment and comprehensive evaluation. The landscape of Alzheimer's treatment is rapidly evolving, with recent FDA approvals of several anti-amyloid therapies offering new hope for patients. These therapies target amyloid plaques in the brain and can help slow the progression of the disease, especially when started early. Your patients with mild cognitive impairment or mild dementia who have a positive blood test suggesting the presence of amyloid in the brain may be candidates for anti-amyloid therapy. Some key facts about these drugs. They are not a cure. They reduce decline by about 30% over 18 months on average, and their long-term effects beyond 18 months are still unknown. These new drugs are monoclonal antibodies and thus require infusions once or twice a month at an infusion center. And these drugs have important risks. So they increase the risk of brain hemorrhage, requiring periodic MRIs, 4 to 5 in the first year of therapy for monitoring for safety. If you suspect your patient is a candidate for these therapies, consider referring them to KU's Anti-Amyloid Treatment Clinic. This clinic improves patient access to these therapies by assessing eligibility, performing necessary tests like lumbar punctures or PET scans, discussing risks and benefits of the drugs, prescribing the medications, and conducting the essential safety monitoring. It's an exciting time in the field of Alzheimer's, with new diagnostics and treatments emerging that offer hope by slowing the disease's progression. By staying informed about the latest developments and engaging in open communication with your patients, you can help them navigate the complex landscape of Alzheimer's treatment and make decisions that are right for them.
Hello, I'm Dr. Jennifer Woodward, and in this video, I'll walk you through the referral pathways and resources available at KU to support your care for patients with cognitive concerns.
As primary care providers, we play a critical role in the early detection and management of cognitive impairment. Our goal is to empower primary care physicians to confidently diagnose and treat the majority of our patients using the tools and workflows we've developed to streamline cognitive care in primary care. While many patients can be effectively managed within primary care, there are times when specialty support is necessary. That's where our collaborative care models come in. By leveraging structured referral pathways, including e-consults, specialty memory care services, and education and research programs, we can extend our specialist expertise to support primary care physicians to manage the majority of patients themselves and refer only the most complex patients. Currently, in the KU Memory Clinic, about 85% of the referrals come from physicians in the community outside of KU. The clinic receives approximately 250 new referrals per month and can really only accommodate about 120 of those per month. The clinic itself has space and resource constraints that limit expansion. Because of these numbers, we need to partner, innovate, and collaborate to improve access to care for patients with mild cognitive impairment and dementia. Here's an overview of the referral pathways in our health system. The three primary pathways are to the memory clinic itself, which has three sub-pathways: the full diagnostic workup and specialty consultation referral, the e-consult, and the anti-amyloid treatment clinic. The second major pathway is the Brain Health Education and Research Center, and the third is neuropsychology. We'll walk through each of these individually in the next slides to review best practices and requirements. These structured referral pathways are designed to streamline your workflow while ensuring patients get the right level of care at the right time. By leveraging these options, you can confidently manage most cases in primary care while having access to specialty support when you need it. Be sure to explore these tools in our electronic health record and don't hesitate to reach out if you have any questions. Hello, I'm Dr. Jennifer Woodward, and I'm excited to introduce you to the cognitive assessment visit tools in our electronic health record. These are powerful tools designed to simplify and enhance care for your patients with cognitive concerns. These visits are so important for primary care because studies have shown dementia is underdiagnosed and that early detection can improve outcomes. Primary care plays a critical role in identifying cognitive decline early. This tool not only streamlines your workflow to provide evidence-based care to patients with cognitive concerns, but also meets the criteria for Medicare Billing Code 99483, which we'll talk about more in subsequent slides. The vision for the cognitive assessment visit is that patients who either screen positive on the mini-cog during a Medicare annual wellness visit, or if the patient or family members report concerns themselves, we would schedule the patient for a 40-minute cognitive assessment visit. This is the visit where you will use the tools shown in this video to guide the visit and ensure all the requirements are met to bill the 99483. After this visit, the patient may or may not have some additional tests to complete, and then typically a patient would schedule a follow-up visit to discuss the results and what the next steps are. As we mentioned, the code that we will bill for this is 99483 and generates 3.84 RVU. For comparison, a 99215 is 2.8 RVU, and a Medicare annual wellness visit is 1.92. I'm not going to go through all of the bullets listed here that are the CMS requirements to bill the 99483, but as you can see, there are a lot. These tools have been designed in a way that if you complete all the steps in the cognitive assessment tool using the tools, you will meet the requirements for the 99483 visit. The backbone of the cognitive assessment visit is a smart set. It includes a standardized note template that guides the HPI with structured prompts. It includes built-in cognitive testing, including the STMS and AD8. It includes orders for labs and imaging and referrals commonly used to assess, diagnose, and treat cognitive complaints, and has clinical decision support information to help guide evidence-based medications and other treatments. It also includes the billing, so you don't have to remember the 99483 code. We will walk through each of these pieces in the next few slides. The first step is to book the visit. We recommend at least 40 minutes for the cognitive assessment visit. Ideally, the patient has a caregiver, family member, or other historian that knows them well also come to the visit with them. The AD8 is a questionnaire that you or the nurses can complete at the very beginning of the visit and enter those results into our electronic health record. Couple just pointers about billings cannot be combined with other E&M codes like 99214, 99215, and also you cannot add the G2211 to these visits. Thank you so much for agreeing to pilot this. We're really excited to get your feedback on these tools. We'd love you to test it out a few times with patients and adjust to your workflow. We will be doing some nursing training. They can help do some of the initial assessments like the 88. Again, kind of plan on 2 visits, a 40-minute cognitive assessment visit and a second visit where the patient comes back to review the findings. If you have any questions, don't hesitate to use the e-consults for that additional support and guidance. And then there are more services coming to the memory care clinic to support us in taking care of our patients. So really, this is a structured approach for cognitive care and primary care. It helps us to complete the thorough assessments, diagnoses, and treatment planning. And then we'd love to hear back, provide feedback, how we can make these tools better, and we'll just continue to improve over time. Thanks again for agreeing to be a pilot provider and helping us to get these tools launched for primary care. Thanks a lot.